So this is something we had discussed already. Because we are having hypotension, this is a very important slide, I would say, and we should just spend some time, because there can be some patients who develop hypotension, and then sometimes we feel like removing this molecule, which is a very important molecule in management of heart failure with reduced ejection fraction. So first thing we should always check is whether they are already volume or salt depleted. Sometimes that may be the case with the other therapies they are having. They are already having very good dose of diuretics, they are having ACE inhibitors, they may be depleted, and then we can start on a low dose, even lower dose, and then go higher. And the thing we already discussed is the dose of diuretics. So we should step down on diuretics once we are starting ARNI, because ARNI is going to give them clinical benefit anyhow. And so this is one of the things we should look at, because other disease modifying drugs like beta blockers, mineralocorticoid receptor antagonists, or we want to give them like SGLT2 inhibitors. So these are not the drugs we want to go down on if they are already on these drugs. So diuretics, we know they don't offer much mortality benefit, especially loop diuretics, and those are the drugs we should down titrate. And with down titrating of these diuretics, definitely we can up titrate the benefits of RB. So again, starting at a low dose is in patients who are having low BP or systolic BP of around 100 and 110, always start with a lower dose. We can start as low as 50 milligram twice daily also we are giving to our patients. We start them on a 50 milligram half BD dose who are having a BP of around 100, and surprisingly most of these patients, they maintain their pressures and they come next time with a better pressure if we are just able to decrease their diuretics, and slowly we can up titrate. In some of the patients, we always don't want to increase every 2 weeks. In these kind of patients, you can take around 4 weeks also to up titrate their the dose of the ARNI, and they have a very good clinical benefit in most of these, even on low doses also. So patients who are already on low doses of ACE or ARBs, or who are NAVE, who are not on ACE ARBs, these are also the patients we should slowly up titrate. So these are some of the very important things we can do to reduce the risk of hypotension. Hypotension is, I would say, is only one of the things which hampers sometimes our management with RB.